Alright guys, so now let's talk about drug eruptions. So whenever we talk about the term drug eruptions, we want to know at least about the term. Drug eruptions basically mean we have a drug that causes a cutaneous reaction, or in other words, we have a drug that causes a hypersensitivity reaction to it, or in other words, drug eruption could be a skin reaction, mostly cutaneous as a result of a use of a drug. Now, of course, this drug is most commonly could be antibiotics, could be a case of anticonvulsants like phenytoin, or it could be a case of antipyretics like diclofenac, ibuprofen, Panadol, and so forth. And whenever we take these drugs, typically there can be a drug reaction. In some people, maybe this drug reaction could take place immediately or within a few hours, or it could take after a month, such as the case of DRESS syndrome. So that's the meaning of drug eruption. Most of them are mild, but there are some cases in which it is very, very severe. Such as the first one was DRESS syndrome, where this one can lead to a possibility of multi-organ failure, which is a very, very bad thing. So now that we've got the definition of drug eruptions out of the way, typically with drug eruption in a history, mostly it could be a case of a 50-plus-year-old female obese who are using multitude of drugs. Of course, drug eruption is not a possibility in such a case unless you can take history from a patient. Maybe a patient could have a rash, and this rash could not maybe possibly be from an infection. This could be due to a drug. So you take history and she mentions you that she uses a drug from like 2 weeks ago, and suddenly she came with a rash, fever, arthralgia. So if you exclude infection, if you exclude other causes, drug eruption could be a differential diagnosis. This is especially important in cases of DRESS syndrome, which is a very, 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 very severe thing that we need to rule out. Okay? So now what we're going to do in this video is that we're going to look at the conditions that is causing drug eruptions. We're going to look at conditions that can cause drug eruptions or are characterized by drug eruptions, let's just say. And we have a lot of them, and each of them we're going to take a brief description or a brief information about each of them regarding their cause, regarding the clinical features, and regarding the possible treatment. Okay? So let's start with the first one. So with the first one out of the way, with the case scenario for drug eruption, the first one is DRESS syndrome. Now regarding DRESS syndrome, the term DRESS syndrome or DRESS stands for basically drug rash, eosinophilia, and systemic symptoms. Or the new term, you have a drug reaction, because it's not just a cutaneous reaction that occurs here. You have a drug reaction with eosinophilia and systemic symptoms. That's what DRESS stands for. And syndrome suggests a group of manifestations. And this DRESS syndrome is a very, 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 very bad thing. All right? And we'll see why. Because you see, in DRESS syndrome, this DRESS syndrome can cause drug eruption. All right? And the cause for drug syndrome is typically drugs. So you can have a hypersensitivity reaction, let's say type 4, all right, a delayed type 4 hypersensitivity reaction to an antibiotic like cephalosporin, or to an anticonvulsant, or to an antipyretic. So let's say we have a patient, all right, that's taking any of these drugs. And let's say he took it from months ago, and now, from like 1 month ago, and now he comes to you with the clinic with complaints of fever, with complaints of arthralgia, with complaints of right hypochondric pain, jaundice, hematuria, as well as lymphadenopathy, and now suddenly this patient has a rash, a very severe rash that spreads throughout his whole body, all right? Could be a maculopapular rash that's very itchy, all right, all around his body. And you're trying to figure out what's going on here, right? He has a rash and he has this multi-organ involvement, and you don't know whether this is a viral cause or this could be a case of DRESS syndrome. So you decide to, during your investigation, if I want to rule out DRESS syndrome, I do investigation, and I found out that his eosinophils is very, very high. He has high eosinophilia. So this gives me an idea that, oh crap, there's a DRESS syndrome here that might be at hand here. And DRESS syndrome so happens to be characterized by a rash especially a maculopapular rash that's all over the body. You don't know by examination what it might be. And it's characterized by multi-systemic involvement or systemic symptoms. I mentioned the liver, I mentioned the kidney, hematuria and pain also, basically pain during urination, dysuria. Also, patient may have jaundice, patient may have lymphadenopathy, patient may have arthralgia and fever. So it has these systemic symptoms. And eosinophilia, that's when I think about DRESS syndrome. Because the thing about DRESS syndrome, and it's also so many organs, it can affect the heart, it can affect the brain, anything. And the thing about DRESS syndrome is that this is a type 4 hypersensitivity reaction. This is when I suspect that this is a case of DRESS syndrome. Because in DRESS syndrome, the thing that's so bad about it is that when you put this patient in ER and you want to observe for 12 hours, he'll have all these multisystemic involvement. And the problem with DRESS syndrome is that if you let it be untreated, this patient can die of multi-organ failure. Multiple systems are being affected, multiple systems are being harmed, because what's going on in DRESS syndrome is that there's a type 4 hypersensitivity reaction due to a use of a drug that the patient used 1 month ago. Right? And that's the thing that characterizes DRESS syndrome even further, is that it doesn't come immediately. No, it comes after a month or two, at least a month. And then you will see all of these manifestations. So DRESS syndrome is something that you should be able to exclude immediately. All right? Because if you don't, the patient can die and you'll be in big time trouble in terms of lawsuits, because this thing could have been preventable. So that's the problem with DRESS syndrome, and these, what I mentioned to you, are the clinical features of DRESS syndrome. You can get it from the name itself or from the mnemonic of it. Okay? Now, the thing about DRESS syndrome is that now that we took the diagnosis and the clinical features and the cause out of the way, the treatment for it is really supportive therapy. You have to give this patient supportive therapy. He has a fever. You gotta find out a way to treat the fever besides giving him drugs that can predispose to DRESS syndrome. Like ibuprofen, I'm not likely to give ibuprofen, but let's say Panadol, for example. Maybe I can give him Panadol. Maybe I can find a way to lower the temperature in any shape or form. So I'm going to do supportive therapy. If he has dehydration, I'll give him IV fluid. So I'm going to give him supportive therapy. And if it's such a severe case, if I am very much afraid of multi-organ failure, I can give this patient steroids. All right, I can give this patient definitely steroids, especially in severe cases. They might say the use is controversial, but seriously, if you have a case of multi-organ failure, saving the patient's life is more important. So you might give this patient steroids along with supportive therapy. And most importantly, the first line management is DRESS syndrome. Besides all of that, is treat the cause, which was a drug. So if I suspect it is DRESS syndrome and this drug he was using for months ago might have predisposed to a hypersensitivity reaction type 4, then I'm going to stop the drug. I must stop the drug immediately. All right? This drug must be stopped immediately, whether it's an antibiotic, whether it's an antipyretic, whether it's an anti-epileptic, all right? I have to stop this drug immediately because this is the one that might have predisposed to DRESS syndrome. So these are the terms of the treatment in general for DRESS syndrome, all right? In general, supportive therapy, stop the drug immediately, that's the first line, and corticosteroids in such a severe case because I'm afraid of multi-organ failure. So the most severe cause or the most severe form of drug eruptions is by far DRESS syndrome. That's something we need to keep in mind. Okay, we finished DRESS syndrome. Now, besides DRESS syndrome, we have other causes of drug eruptions. One of them is really joined up together: urticaria and angioedema. Let's see what's urticaria. If you remember in past videos, urticaria is basically a condition in which a patient feels very itchy. He has primary skin lesions which are red and itchy, and they come and go every 5 to 10 minutes. And urticaria is basically a type 1 hypersensitivity reaction where there's the involvement of mast cells that release histamine. That's why you feel itchy. That's why the patient feels by the redness. That's because of the histamine that promotes itching and vasodilation. And the cause of urticaria could be numerous. Could be due to a drug. It could be a case of immune related. Could be due to type 1 hypersensitivity reaction to an allergen or to a drug or anything. Or my marker just dropped. Or it could be a case of non-immune mediated. Yes, you could have a case of urticaria without the involvement of a hypersensitivity reaction. And that can be the case of infamously ACE inhibitors. Remember ACE inhibitors, the one that end with pril, captopril for example? These drugs that are given for hypertension, especially for people with diabetes. And these type of drugs, what they do is that they inhibit the ACE enzyme so that eventually we can have vasodilation or indirect vasodilation and lower the blood pressure. But the thing about ACE inhibitors is that when they inhibit the ACE enzyme, this ACE enzyme, its main purpose is to inhibit, or not inhibit, to break down bradykinin, an inflammatory mediator. So if I inhibit the ACE enzyme, the bradykinin levels will increase because the enzyme of ACE, its purpose was also to break down bradykinin. So ACE inhibitors can indirectly increase the level of bradykinin, and bradykinin, one of its functions is also vasodilating, basically vasodilation as well as itching. It's an inflammatory pro-mediator. So you could have an urticaria occur to you as well as angioedema due to the high levels of bradykinin. So that's a non-immunomediated cause. So urticaria can be immunomediated related or it could be non-immunomediated related. And the clinical features, as we said before. Of course, the treatment for urticaria is really, if I have a case of ACE inhibitor, I can replace it with ARB, angiotensin receptor blockers. I can give him losartan, for example. It will not prevent it completely, but there's less of a chance of it occurring. If it's immune mediated, maybe I just find out the cause of it and treat it. And if necessary, I can give the patient antihistamine, all right? Now, the thing about urticaria and really angioedema, I'm really afraid of one thing, and that's anaphylactic shock. So if I see a patient, especially with urticaria, which is characterized by a primary skin lesion known as wheals, that's the reddish erythematous itchy lesion that patients with urticaria have, wheals filled with edema, raised lesions filled with edema. If these patients have urticaria or angioedema, which means swelling of the face, all right, or around the eyes or the face or the tongue, if patients have these, I need to rule out anaphylactic shock because these can be signs of anaphylactic shock. So whenever a patient has urticaria or angioedema, I must check the blood pressure and monitor the pulse as well to rule out anaphylactic shock, because if there is, this can be a big bad thing. All right, so that's something to keep in mind with urticaria and angioedema. They should be treated, or they should be really seen as a serious thing. All right, because it could be part of a very, very serious thing. So we finished with urticaria and also angioedema. Angioedema is the same thing. The cause could be either immune or non-immune related, as we said with mast cells. Again, the clinical features, typically with angioedema, there's swelling, all right, especially around the face, angioedema, especially around the eyes, periorbital, or in the cheeks in general, or it could be in the case of the tongue. The thing about angioedema is also can be serious, especially if angioedema, if there was swelling, all right, around the larynx. If there was swelling or around the larynx or laryngeal edema, this can cause the patient to have dyspnea, as well as the fact the patient could have stridor. He might have a case of a stridor, which is an abnormal breath sound. And the thing about laryngeal edema is like this can completely obstruct the airflow. So this is a very serious thing that angioedema should be taken care of, all right? And typically patients may have urticaria and angioedema together, or one is its own separate thing. I like to think of it as together to rule out the bigger picture, especially with angioedema and urticaria, which is anaphylactic shock. And the treatment is you treat the cause, you know? So that's pretty much it. The cause is the same for both of them, urticaria and angioedema in general. And that's pretty much it. The clinical feature, one is swelling, the other is a primary skin lesion. Now we finished those first three. They're really the serious ones. Now let's talk about the most common cause of drug eruptions, which is drug-induced exanthems. Now the crown here represents the most common cause. And the most common cause, like we said, of drug eruptions is by far drug-induced exanthems. Exanthems, or let's say you might have heard this term before in viral infections such as measles. Measles are characterized by exanthems or maculopapular rashes throughout. And so here's the thing, it could also be in measles or it could be also involved in other drugs. All right. So in the case of drug-induced exanthems, you might see the patient presents with measles-like presentation or morbidly formed maculopapular rash throughout, and you don't know if this might be a case of measles or be a case of something else. Along with this rash, people may present with fever, itchiness, all right, as well as eosinophilia. And this eosinophilia could differentiate for you this exanthems either is a drug-induced or could be a case of measles, all right, a viral cause. But typically the cause of drug-induced is from the name, drug-induced eczenomas. You have a case of a type 4 hypersensitivity reaction. Again, you have a delayed type 4 hypersensitivity reaction to any drug, maybe an antibiotic, maybe an antipyretic, maybe an anticonvulsant, anything. All right, and you have a drug-induced eczenomas that might occur a little bit sooner, maybe 2 weeks, after exposure to this drug, or 2 weeks after exposure to an allergen. All right, but let's say mostly a drug. All right. And the thing about drug-induced eczenomas is that this also still should be considered or treated as a serious case. Because, by the way, drug-induced eczenomas, this clinical presentation, if you notice, it's quite similar to DRESS syndrome. All right, so people consider drug-induced eczenomas as maybe the beginning of DRESS syndrome. Before any systemic symptoms, you might see the beginning of DRESS syndrome or the beginning of toxic epidermal necrolysis in the case of drug-induced eczenomas. So drug-induced eczenomas should be treated as a serious case because this may be the beginning of such a serious case such as DRESS syndrome or TEN. So we should treat it seriously as the same. And regarding the treatment for drug-induced eczenomas, you find out the drug. What might be the drug that might have predisposed to it and stop the drug, as well as giving the patient antihistamine if he feels itching, supportive therapy in general. Okay? So that's pretty much it for the drug-induced eczenomas. And besides the drug-induced eczenomas, the next one is hypersensitivity vasculitis. Now here you have a case of a purpura, all right? There's extravasation of blood as a result of damage to the blood vessels. And why is there damage to the blood vessels? Because there's inflammation to the blood vessels, vasculitis. But this inflammation involves, like I said, inflammation, hypersensitivity reaction, specifically type 3. There's an antigen-antibody complex that deposits itself in the blood vessel, and thus inflammation will occur to the blood vessel and edema, and this will lead to the form of a purpura, which is basically bleeding leaking out. All right, bleeding and fluid leaking out. Now the thing about hypersensitivity vasculitis, we already said the cause. It's a type 3 hypersensitivity reaction to a specific drug, all right? It could be a case of an anti-gout drug in hypersensitive vasculitis. It could be a side effect of allopurinol, which is a drug used for gout. Or it could be a case of antibiotics like cephalosporin or anticonvulsant, phenytoin. So a type 3 hypersensitivity reaction to an antibiotic or an anticonvulsant or an anti-gout. Or it could be found in a case of a person who finds milk. Let's say we have a patient, all right, let's say we have a 25-year-old patient, all right, and he presents to you with a palpable purpura. Yes, you have a purpura here, and it's non-blanching like usual, differentiated from erythema. It's non-blanchable, and it is basically palpable. You can palpate the purpura here, all right? You can palpate it because a palpable purpura is basically like a papule. It's like a plaque that's filled with blood. So you can actually palpate it, you can feel it. And you find this typically in your lower limb, all right? Let's say we find this palpable purpura in your lower limb, not above the knees, so basically in the chin and in the feet, all right? So you find this in a 25-year-old, and you find he has, along with this, a maculopapular rash, he has a fever, he has arthalgia, and when you do investigation, you'll find he has neutrophilia. Now, let's say we take a biopsy as well. Let's say we take a biopsy from this purpura I was able to feel in the lower limb. Then I take this biopsy and I see the presence of neutrophils around this artery, around the lumen of the artery, and I see the high levels of ESR as well. So what I think of when I ask the patient, does he take any drugs? He tells me yes. I took a drug maybe 1 or 2 weeks prior, and it was, let's say, cephalosporin. Or let's say he drank large amounts of milk. He doesn't take a drug, but he drank large amounts of milk. That's when I think about hypersensitivity vasculitis. Because milk, actually, any type of milk that you drink contains antibiotics. So a person who drinks a lot of milk and may present with the features I just mentioned in hypersensitivity vasculitis, such as a palpable purpura, especially in the lower limb, along with a maculopapular rash throughout his body, and fever and arthalgia, and with high amounts of neutrophils, whether on biopsy or investigation, and high levels of ESR, that's when I think about hypersensitivity vasculitis, okay, as a possible diagnosis. And there's a criteria for it, which is what I just mentioned to you right now. that a patient has to be more than 16 years old, that a patient has to have a palpable purpura, that the patient has to have a maculopapular rash, as well as a fever, arthalgia, and when you take a biopsy from this purpura, for example, you'll see high levels of neutrophils around the blood vessels, okay? So these are the clinical features and the criteria you could follow with hypersensitivity vasculitis, which is again inflammation of the blood vessels due to a type 3 hypersensitivity reaction, either due to drinkage of milk, which actually contains antibiotics, or actually taking antibiotics like cephalosporin phenytoin or allopurinol. Okay? And regarding the treatment, you treat the patient here according to the cause, right? If it's antibiotic, you stop the antibiotic. If it's anticonvulsant, you stop anticonvulsant. If it's the milk, stop with the milk, along with supportive therapy. Okay? That's pretty much it for hypersensitivity reaction. The next one is erythroderma. Now, regarding erythroderma, from the name, erythro means redness, derma means skin, and that's what erythroderma is. You have what is known as red man syndrome, let's say, in which you have complete redness all over your body. There's erythematous, basically here you have erythema, let's say, a cutaneous reaction of erythema about 90% of your total body. So 90% of your total body surface area is filled with erythema or erythematous rash, okay? And the thing about erythroderma, all right, the cause of it could be seen as a complication of whatever disease. So erythroderma could be a complication of atopic dermatitis, or it could be a complication of T-cell lymphoma, or it could be a complication of P, cirrhosis, for example, or it could be a complication of certain drugs, up to 10% of cases. Drugs such as gold, somebody uses gold, like in the case of rheumatoid arthritis, may develop erythroderma as a complication. And the thing about erythroderma, think about it, when you see erythema all over the skin, what are you afraid of? Well, let's see, erythema occurs why? Because there's vasodilation, right? There's a lot of blood vessels that's being dilated and they release heat. And heat comes redness and whatnot. But that's the thing, I'm releasing a lot of heat, all right? So if I'm releasing a lot of heat due to vasodilation, and of course vasodilation occurs because we have increased blood supply going to this region, the problem is now most of the blood supply of the body is going to the skin. So now the heart in its cardiac output is going to be high, but most of this cardiac output is going to the skin that's being vasodilated and releasing a lot of heat and redness, right? So if most of the blood supply is going to the skin, what happens to the rest of the body? What happens to the heart? What happens to the liver? What happens to the kidney? And that's exactly the problem right here, especially to the heart. You might have a case of high output cardiac failure if erythroderma is left untreated. So erythroderma could be one of the potential causes of high output cardiac failure, joining with anemia, cytotoxicosis, and pregnancy in some cases. So that's something we need to keep in mind as well. So the case with erythroderma, here you treat the cause. If it's a cause of psoriasis, we give supportive therapy. We treat the inflammation because typically these are associated with inflammation that may involve vasodilator mediators, and they cause vasodilation throughout. And we basically, that's that. We treat the cause and give supportive therapy, okay? So remember erythroderma, from the name, complete redness, up to 90% of the total body is completely red. Okay, and that's very bad because that can lead to high output cardiac failure, and not just that, you're losing a lot of heat as well. You're not even in a hot weather and you're losing a lot of heat, so this can lead to the person basically his temperature going down. So that's something also to keep in mind as well. The rest was erythroderma, all right, 90% of the body. Next is Stevens-Johnson syndrome. Now, Stevens-Johnson syndrome and toxic epidermal necrolysis, they're really a part of the same spectrum, meaning they really represent some of the same clinical features, same or some of the same concept. Basically what it's trying to say here is with Stevens-Johnson syndrome, this is another serious complication. You might see some antibiotics like sulfonamides, for example, certain antibiotics such as sulfonamides, or it could be a case of anti-drugs in general, antipyretics or whatever. And overall, you have a hypersensitivity reaction to these drugs, okay? And the thing about these hypersensitivity reaction, after 1 to 3 weeks, you might eventually develop Stevens-Johnson syndrome. And in Stevens-Johnson syndrome, this one is basically a syndrome in which it affects less than 10% of the body total surface area. So not 90% like erythroderma, but it can be less than 10%. So let's say 1 to 9% of the total body surface area might be affected, in which the patient with Stevens-Johnson syndrome may present to you with crusts and erosions. Especially in the mucosa. You might see crusts and erosion and redness, especially in the conjunctiva. That's an example of a mucosa, or in the mouth as well. That's another example of the mucosa as well. So any part of the mucosa, the oral mucosa or the conjunctiva, these can be affected absolutely. Stevens-Johnson syndrome. You might see a couple of primary skin lesions or secondary skin lesions, such as crusts and erosion and redness throughout. And you might see in the chest, especially in children, and that's what Stevens-Johnson syndrome mostly occurring in children, you might see a case of iris or target lesions that resemble erythema multiforme, another condition that you might see as well in the chest as well. And the treatment here is, you treat the cause. What might have caused a hypersensitivity reaction? What drug might have caused this issue? And so forth. Okay? So that's Stevens-Johnson syndrome. That affects less than 10% of the body, total body surface area, due to a hypersensitivity reaction to a drug. And after 1 to 3 weeks, patient may present to you with crusts and erosion, especially in the mouth and in the eyes. This occurs mostly in children. And you might see in their chest iris or target lesions, a group of plaques, let's say, a group of papules that basically appear as target lesions, similar to another condition known as erythema multiforme. Okay? Now, what if I told you that we have a case that's similar to toxic epidermal necrolysis, but this time it involves more than 30% of the total body involved. So 30% of the total body involved may be here at hand with toxic epidermal necrolysis, meaning skin lesions will be appearing there as well. So if you look at it as a spectrum, Stevens-Johnson syndrome involves less than 10% of the total body surface area. Then between 10 to 30%, could be an overlap. There could be overlapping of the Stevens-Johnson syndrome and the toxic epidermal necrolysis. Then when you have more than 30% or 30% and more of the total body surface area being affected, meaning there are lesions in approximately this much of the body, then we consider this as toxic epidermal necrolysis. Now from the name, there's going to be necrosis in the epidermis. And you see the problem with toxic epidermal necrolysis, you'll see that the patient, he appears like a lizard. You know lizards, their skin, they tend to shed a lot. The similar here in human beings. You might see in this patient that his skin is being shredded. Constantly, there's dead skin that's constantly being shredded to make up for new. So you'll see one skin that's being heavily discoloration, there's heavy discoloration, while the other might be normal in comparison. So you'll see shedding of the skin. And of course, the skin itself might be very painful. The patient might see that the skin is very painful, that he's not able to tolerate it, and he might see the presence of a bulla. There can be presence of bullas in his skin as well. If you don't remember what a bulla is, it is basically primary skin lesion, a raised lesion, that basically can arise between the dermis and the epidermis. Okay, filled with fluid or air or anything. Okay, so that's what the patient with toxic epidermal necrolysis. If you look at pictures, patient may appear with shredding of the skin. Some of the skin may be shredded, some of it can have bulla as a primary skin lesion. Again, 30% of the total body could be anywhere up to 30% in total, as well as painful. The experience can be painful for the patient. Okay, and the treatment here is really. Treatment is you treat the cause. What could be causing toxic epidermal necrolysis, which by the way, the cause of both are very similar, all right, for both Stevens-Johnson and toxic epidermal necrolysis. You treat the cause, okay, and along with supportive therapy. Maybe you give this patient steroids if you need to in severe cases. Now let's go to the last two. We have fixed drug reaction and photosensitivity. Now, fixed drug reaction basically means that you have a lesion at the same site whenever you use a medication. So let's say we have a patient, all right? Let's say we have a patient here that has a drug reaction, all right? Let's say he has a drug reaction to a antipyretic or antibiotic or anticonvulsant, any of those three, all right? Let's say to cephalosporin. Let's say you take cephalosporin, Then after a couple of few weeks, he develops a hypersensitivity reaction, a drug reaction, and it occurs in his left shoulder. All right, there's a primary skin lesion that developed in his left shoulder. Then let's say he stopped the drug. Then after 5 years, he took the drug, and the same lesion appeared again at the very same site, the left shoulder. Then what do we call this? This is a drug eruption, but it's known as a fixed drug eruption. The location is fixed. The primary skin lesion, whenever you use the same drug more than once, will always be fixated on the same site. Okay? So that's what fixed drug reaction is. And in case of fixed drug reaction, it is characterized by the following. Primary skin lesion is an erythematous edematous plaque. You might see a plaque, which is a raised lesion, more than 1 cm, in which you see an erythematous plaque anywhere around the body, let's say the trunk, and it is basically edematous. It might resemble psoriasis, by the way, just to keep in mind. Erythematous plaque that might eventually, with over time, if this disease progresses further, might develop into hyperpigmented macules. So you might see the presence in a late case, either a hyperpigmented macules, especially throughout the body, or you might see in an early case, before it progresses into hyperpigmented macule, an erythematous plaques that resembles the ones that you might see in psoriasis. Okay? You can always look at pictures for each one to get an idea. And the treatment for fixed drug reaction is to stop the drug that might have caused this, and really supportive therapy. Because if you have a constant allergic reaction or hypersensitivity reaction that leads to these manifestations and is always at the same site, you can see this as fixed drug eruptions. You can tell them to stop the drug, use another drug if you have to, and in serious cases, maybe topical steroids if need be. And also supportive therapy. So we finished fixed drug reactions. Now the last one is photosensitivity reaction. And photosensitivity reaction means a patient takes a drug, and this drug will cause drug eruption, all right, like any usual. And here's the thing, when the patient who takes the drug is exposed to the sun, this will cause a photosensitivity reaction, and this is a form of drug eruptions, all right? It means sensitivity to the sun that will affect the drug. Now, the thing about photosensitivity, there's 2 types we need to keep in mind. There is the phototoxic and the photoallergy reaction or eruption. Now, the phototoxic is the much more common type, okay? With the phototoxic, basically we have a phototoxic eruption, which is one type of photosensitivity reaction. Basically what happens is, let's say you take a drug, all right? Let's say you take an antibiotic or any drug, let's say an antipyretic. I took a drug and I went outside, and now the drug is in my system, is in my blood. And now let's say I'm exposed to the ultraviolet rays from the sun. And this ultraviolet rays from the sun is going to be absorbed by the drug that I just took. And the thing about this drug is that it can absorb some of these ultraviolet rays, and it can release back an energy that can be dispersed throughout the nearby cells. And those nearby cells could happen to be the skin. And thus this energy could be blasted towards this neighboring cell that the drug is in, circulating in the blood, especially that of the skin, and this can cause damage to the cells. And if there's damage to the cells, then this can lead to inflammation. And this is what is known as phototoxic eruption, in which there is no hypersensitivity at work here. There's no immunomediated or anything. There's just the fact that the drug is absorbing some of the ultraviolet rays, and it's basically reflecting it back, this damaging rays, to the neighboring cells, causing inflammation, causing the person to appear with a case of a sunburn, let's say, all right? A case of a sunburn that might develop into a blister later on in a patient. So that's the clinical presentation, all right? A sunburn. Now, this is phototoxic. Then what about photoallergic? Now, this one, yes, this one involves hypersensitivity reaction, let's say type 4, in which, yes, in photoallergy, what happens is that, again, the same scenario, patient took a drug, went outside, the drug is in his system, in the blood, and he's exposed to the ultraviolet rays. Here, this time, the ultraviolet rays will change the composition of the drug that the patient just took that's in his system. And it will change the composition so that it will have an allergen that the body might deem as abnormal. So now the immune system sees an allergen that was developed as a result of ultraviolet exposure to this drug. So it will take the allergen or the antigen and it will present it to the T lymphocytes. Adaptive immunity will be activated, memory T cells will be activated, antibodies will be developed, and as a result, you'll have a type 4 hypersensitivity reaction in which antibodies will be developed against an antigen of the drug that was chemically modified to ultraviolet ray exposure. So this is known as photoallergy eruption. Okay? So these are the two types of photosensitivity reactions we need to keep in mind. The more common one is phototoxic eruptions, and in both cases, patient may appear with a bad case of sunburn, or let's say to be more specific, in a case of photoallergy eruption, patient may present with rashes, maybe maculopapular rashes or erythematous rashes, and in that case, here you might have to have the patient in the treatment, you might tell the patient to not go outside or cover as much of himself as much as possible, or if you have to, you need to change the drug to something else that you, inshallah, will not be affected by the ultraviolet ray at all that is emitted from the sun. Okay? So that's pretty much it for the treatment of photosensitivity, and these are all of the conditions that are examples of drug eruptions. Remember, the most common out of all of them is drug-induced exanthems, the crown, the king. The most severe is DRESS syndrome, the one that are associated with anaphylactic shock, urticaria and angioedema together, all right? And the ones that have really a spectrum, let's say, that is Stevens-Johnson syndrome, which is 10%, less than 10%. Then between 10 to 30% is the overlapping of both Stevens-Johnson and TEM. And then when you have more than 30% of the total body involved, that is toxic epidermal necrolysis, all right? And let's never forget about fixed drug reaction. What does it mean? And let's not forget as well about photosensitivity reaction, the two types. What are the differences between the two? Okay, that's pretty much it. I hope you enjoy. And also, let's not forget about hypersensitivity vasculitis, the criteria for it. All right? Thank you.